Hey, everybody. My name's Hadley. I'm a nurse educator. I've been working with pre-licensure BSN students and pre-licensure ADN students for the last 16 years or so. Currently at a community college in pre-licensure ADN, and I teach many courses across the curriculum: fundamentals, health assessment, med-surg courses, geriatrics. Have taught community healthcare. Um, But one of the startling facts that I keep coming back to, whether you define me as a seasoned educator or not, is the word socialization of our nursing students. What does it mean, and what is our responsibilities as nurse educators to not only role model socialization, but how to prepare students for the nursing world once they complete the nursing program and are successful on boards? What are we doing in program to help them socialize to the role of, upon graduation, would be a novice nurse, for example? It's not okay to say that once they exit the program, they become their employer's problem. They become their employer's faculty, excuse me, staff, and that socialization with the integration of novice to seasoned nurse over many months, years, etc., can be very daunting for that student grad. Can be very difficult because even though it's a transition to practice, the last course in whatever pre-licensure program they're in, what have we done in program to help them identify the role of a student nurse? And what does that mean? Whether you work with non-traditional learners or traditional learners, whether you use VARC assessments to analyze your students' teaching learning styles, whether you're a certified nurse educator, CNE, whether you're BSN prepared and doing clinicals, or you work in nursing education with a master's or a higher degree, it is our responsibility to, and I don't like the word softer sciences, softer skill sets, but we're responsible for accountability, integrity, doing the right thing when nobody's listening, nobody's watching. But how do we teach that? How do we teach students to recognize behaviors? How do we recognize, how do we assess where the student is in their life, their age? Are they a Gen X? Are they Gen Y? Are they millennials? Are they alphas, born after 1997? What do they take seriously? What's important to them? How do they learn? Again, visual, auditory, tactile, kinesthetic, combination of all the above, X, Y, and Z. Um, so those of us who are really good at curricular development, curricular design, competency-based course content, assessments of academics, assessment of clinical proficiency, minimal competency to graduate based on meeting clinical objectives, etc. Meeting end of program SLOs. What does it mean? What are the steps? Where is the guidance for nurse educators via administration, college administration, program administration, to teach us the toolbox and the tips of how to get our students to socialize into the role? What does that look like? Um, we have our domains of learning: cognitive, psychomotor, um, affective. So, how does that play into it? Now, I'm, in my early 60s, and I got my master's in nursing ed in the early 2006 through 2009, if you will. I don't remember being taught how to teach people, nursing students, how to socialize in the role of identifying as a student nurse and then an RN. It wasn't really part of our curriculum as a student. And so, what does it look like now? And what is that? How do we, if that's a gap in our education 10 plus years ago than what is being done to assimilate us as educators to add those components to our classes, our simulation, our lab, our skills, clinical settings. Yeah, we're expected to role model professionalism. We're expected to be available. We're expected to be non-judgmental. We're expected not to eat our young. We are expected to be available and helpful. I mean, there's many different kinds of, let's say, advising. There's prescribed, there's behavioral, there's intuitive types of advising, and everybody has a model of advising, and it doesn't really, we're mandated to advise students, so but we can pick any model that works best based on the student's need. And identifying at-risk students, for example, there's advising components that can meet that um, access for us as educators to facilitate and help the students. But how do we do that in the classroom when we have the students, one assumes, front and center and engaged in activities? And one of the ways that, as seasoned as, because of the number of years I've been in higher ed of nursing programs, is to set boundaries and expectations on day one. I'll give you an example of what I used to do. I would spend the first day of class, instead of just spending 3 hours doing orientation, I would spend a good 45, 50 minutes or so. And then we dove right into content because of 16-week med-surg course. These kids are with me 3 hours once a week. We have a concept-based curriculum, and we have multiple exemplars, aka disease processes, that we're required to teach. So for every 9 hours of content, there's an exam. So every 3 weeks or so, there's a content exam based on, our testing platforms. So how do I socialize the students in the classroom? What are my expectations? So when you have a diverse population of students, non-traditional, traditional, and then you've got various age groups, so they fall into different life patterns of the Gen Xers, the Gen Ys, the millennials. We don't see a whole lot of baby boomers born before 1964 per se. But most of our classes, our folks are late 20s into early 50s. But we do have a few students that were born after 1997, so they're very tech savvy. I mean, they don't even know what a rotary phone looks like, for example, or maybe even how to write a check. But so when you're dealing with all of that diverse population, how do you rope them all in to address socialization? So one of the things I came up with is called psychological safety. And we see that sometimes termed in clinical settings, because in clinical settings, we are guests in the facilities that we are working with our students. And so there's always the consistent discussions about the way students are treated, quote unquote, on the unit, or how non-receptive, the RNs are. But we're not supposed to be assigning students to the nurses. We're assigning students to patients, and we are the responsible party for the students. We don't sit there and farm off our students to RNs. That's not okay. And we can get into that if folks want to chat about it. But you really have to understand what psychological integrity means in the classroom. How do you build a safe environment that drives a smaller community within the community of the cohort? We have roughly 90 students every semester. We admit twice a year. So all of our courses now are 3 sections with a max of 30 students per cohort. So it's relatively small in the sense, especially if you're coming from a university setting where you have an auditorium full of students and you have numbers, versus really getting to know the students. So we have to consider part of the socialization on day one, reviewing the syllabus, reviewing questions regarding grading. Students are more focused on what that 100% and that 80% benchmark to pass the academic side of the course. What does that look like? What am I required to do? But how do you set up boundaries? How do you define incivility? What does that look like? Because every age group in that class has a different definition of incivility. Your alphas are always on their cell phone. So are they being incivil because my age of 60, considering you're on your cell phone the entire time of class, I consider that you're not engaged. Well, maybe they are engaged because they're using the cell phone to do research and Google questions that I'm asking in class, and they're looking for responses to assist them with the answers. So sometimes we have to step out of ourselves to really find out what the socialization of the nursing student look like. And we have to look at ourselves first as individuals and reflect back on where we are in our journey as educators in our age group. What does that look like? And so before we make presumptions, before we pass judgment, before we eat our young and set up an environment that becomes, I'll use the word toxic and non approachable, we have basically, by that non reflective of what we want to see in our classroom, because we don't know what it is, have automatically taken the socialization out of the equation. And so when you teach like that, when you present yourself like that, we are continuing the continuum of our student nurses graduating, going into the nursing field, and treating everybody else the way they were treated in school. So it's like we have to break the cycle. So setting up boundaries, setting up expectations. What are your expectations? What do you want on day one from your students? You want to be on time? I had a student last semester who worked nights. No way around it. But she wanted to be in my class, which started at 9 o'clock in the morning. Did she ever email me to tell me she was late? No, there was no college policy that you had to notify your instructor either you're going to be late or absent. I asked as a courtesy, so I didn't worry about where you were. But this student, it was never personal. It was never any attempt to be incivil. Always walked in the class anywhere from say 9 to 9:30, and sometimes as late as 9:45. Now, instructors could very well say, the door is closed and you can't enter until our first break, which is usually 50 minutes in on a 3-hour course. Is that your response to incivility? What do you think that's going to do? What do you think that's going to change in that student? Is that going to set up an approachable communication with that student? I've had faculty say, well, that's her choice to work nights. Well, how do you know it's her choice? How do you know? She makes more money working the night job than she does working as an EMT. So you're going to drive a bus and struggle making money, or are you going to make the money you need so you can buy your books? You have less financial aid needs, less loans to pay back upon graduation. So what do? That's where the reflection comes in. That's when we sit down, or I sat down with myself and said, because initially I was irritated. I'm like, wait a minute, this is a pattern, A. B, the student doesn't see it necessarily as a pattern. Not being able to step outside of herself because she is early 30s, so it's non-traditional learner. So I took her aside and say, help me understand. And she was embarrassed because she did not recognize, because of where she is in her lifestyle based on her age and the definition of that student, did not see it as being incivil. All right. So the socialization process becomes our responsibility. Open up your minds, step out of your preconceived notions, the way that you were taught in nursing school, or how you were treated in nursing school, or how you were treated as a nurse on the unit before you went into education, and stand back and reflect. Because what you're doing is, by not reflecting, you are in essence not part of the change agent. You are perpetuating the continued profession of incivility. And we are not socializing our students to change that culture. And that's where it starts in the classroom, is setting up the boundaries. So what I'm going to do this fall is say, look, I get it. Life's there. Life happens. But if you know it for a fact that you cannot be in class by 10 of 9 because you work nights, or you have to drive whatever distance, or you've got kids to put on the bus, you've got your life and you're trying to navigate it, come see me. Because I may not say it's an extenuating circumstance, but it's a circumstance that is impinging upon the student being successfully able to be in class on time. I will work with that student. That's socialization. That is the way to treat others in a way they need to be treated. They will remember that. Kindness goes a long way. So it's not just a psychological safe integrity and clinical, because again, we're not in an environment we can control. When the classroom and the lab or in campus nursing lab simulation, we can control that environment, right? Um, but you have to really step back and look at, what does that mean? How do we do that? How do we provide the environment and the opportunity for students to ask questions, to respond to the whys? What if you have a student who is a wallflower, just as an introverted student, really struggling to find their voice? And if you are an instructor, say in simulation, where you don't assign roles, such as a med nurse, bedside nurse, documenter, for example, if you have more than 2 students in a simulated experience, and this student always chooses the documenter, which can become a very passive, non-engaged role. Not using psychomotor skills to do a head-to-toe assessment, not doing effective learning by assessing the patient's emotional and mental status, the cognitive domain across the board of application, and engaging in the simulation to improve the patient, to affect the outcomes at the end. So what do you do? Do you keep allowing the student to be the documenter? Are we too busy to recognize that the student is found a comfort zone that is going to hinder their progress? And the answer is yes, it's going to hinder their progress. So what would you do? What is the direct result of recognition, assessment? You've diagnosed it. What is your plan? And then how are you going to fix it? How are you going to intervene? You meet with the student. Say, hey, I noticed that. I assessed that. Each time you come to sim, you choose the documenter role. Let's talk about why. How can I get you to be more comfortable being at the bedside, talking with the patient, listening to heart and lungs? What is it where's the gap for you? Where is the fear, basically? So very short little live kind of thing going on, but very valuable information. So even if you're a novice educator and just coming in from different fields of nursing and you're coming into academics, the first thing you need to do is evaluate yourself. Reflect, is what do I want to present myself to be to my students? But setting up borders and setting up boundaries of ways that you can protect your own self-ego, but still be available for your students. What if you're the same age as most of the students in that classroom? You're not their colleague, you're not their peer, you're their instructor. You're not their friend. So how do you make sure that the boundaries are clear and professional? How do you do that? How do you protect your identity as an instructor? Once you understand, we don't use the word pedagogy, is pretty old at this point. There's another type of goji out there that sometimes we as nurse educators really don't know how we want to teach content. We may not even know what activities to do in a classroom to reach all learners. Lecture, we know, historically does not work. It's passive. You're not going to get students engaged. You're not going to develop clinical or critical reasoning, judgment, pick whatever PC word of the year we're in. Maybe you're not fond of, case studies and engaging activities. You've really got to hold your classroom very tight if you're going to let the students do group work, because you're going to have to set timers. You're going to have a very well versed or rehearsed responses to all the responses you expect to get as the case study unfolds. You have to be accountable to the material and the content, and you have to know what you're talking about. So if you're not there yet, that's part of the reflection, okay? Because it's all wonderful, these activities, and let's give the students the work to do. That's great, but you better have the answers when they come back at you. Because if you're a novice and you don't have, they will eat you alive and spit you out. And quite frankly, they should, because you should not be taking on a role that you haven't yet figured out how to be the best at in your current state as a novice. If you're a seasoned educator, maybe you're used to the way you teach and thinking about doing something new, because most of us don't want to change what we're comfortable with doing. Well, maybe pilot a program from other nurses who are willing to take on that technology, for example. And let's see how it works from those that want to do it. Doesn't mean just because you're not a fan of it, because you don't know how to use the product, doesn't mean it's an automatic no, right? I'm not, I'm very honest with my students. I am not a tech guru. I'm lucky if I can get the whiteboard to work on a Tuesday basis. And they laugh with me because honesty is makes me human because I am human. But you have to reflect on yourself. What is it about being a novice nurse? If you're a clinical instructor as a secondary position, you don't work full time for the university or the college, what are you doing it for? Is it extra money? And that's all it is? Or do you have a vested interest in the psychological integrity and safety of your students to help them learn how to prioritize and how to concept map the patient's clinical presentation back to the labs and the diagnostics and come up with a hypothesis of what's wrong and what 3 priorities is the student going to do to fix or improve the patient's clinical status the day they're on the unit? Are you willing to work that hard to have that result at the end of the day? Do you know how to do Socratic method in post-clinical? What does your clinical post-briefs look like? Who's mentoring you to help you assimilate that role as a clinical instructor? Classroom integrity, classroom clicking for students or the aha moments, they don't happen in the classroom. They happen in clinical. So quite frankly, I've done this job long enough and I've been in several leadership positions. If you're in it for an extra paycheck, please go someplace else. Don't do this, because if all you're doing is collecting, 8 hours at whatever, $40 an hour, and you have no vested interest in improving the profession of nursing and improving the quality of the person and instilling behaviors and working with the student to be minimally competent upon graduation to help smooth their transition into the RN role, then go do something else. But I think for the most part, those of us who go into nursing education or any form of teaching, you have to want to do it. Historically, we know that private practice pays better. Unit floor nurses, hospital staff make more money than nurse educators do. You have to be in nursing education for a great deal of time to see any real growth financially. And I've been teaching since 2009. I'm 4 years shy of retirement, and I wish I knew 4 years ago, 5 years ago, what I figured out in the last 2 semesters. It's time. It's taught me, students have taught me how to be more flexible, how to be more gentle, how to be more kind, how to be more caring. Because I was one of those stoic academic instructors that extenuating circumstance, no, you don't get one. This is a nursing program and you better buck up or find something else to do with your life. You know what? I really was continuing to eat my young, and I call my students my kids, and they are. And my boundaries are set in stone. You don't call me by my last name. You call me by doctor and then my name. You utilize the appropriate communication channels. They have my cell phone number. All my students have my personal cell phone number. Not one of them has ever used it inappropriately, ever, because I set the boundary. I set the tone. And it doesn't matter how old you are. You could be 35 with a master's degree and go in and teach pre-licensure. You set the tone and you will be fine. But you have to socialize yourself first to what that looks like. So I hope this was helpful. I hope everybody has a wonderful day. I look forward to feedback. Thank you.